Hello, everyone, and good morning again. I'm going to be introducing our next speaker. His name is Dr. Chiang. He will be giving a presentation on the topic of cholestatic and autoimmune liver disease. Thank you.
Thank you, Ray. All right, so trying to make it short and sweet. Thank you for everyone for coming to a Saturday morning lecture. This is unbelievable. Today, I will talk about some updates in autoimmune and cholestatic liver disease. When I go to liver meeting and try to summarize it for people here, I try to focus on two things. One is what are the information you can take back to the clinic next week. That's number one. And number two, I'm trying to answer some of the questions I have in my mind on the disease of interest. And specifically this year, there are three questions I have in my mind. One is with the new approval of two second-line agents in PBC, which patients should you use and which one should you choose? That's the first question I have in my mind. The second question I have in my mind is what do I do with the PSC patients that I have no drug to treat? Okay, what do I do when I see them in clinic? So that's the second question. The third question is an age-old question of this AIH PBC overlap syndrome. What do you do with those patients that can be difficult to treat? So those are the three questions I have in mind, and I hope I'll provide you some information that you can take back to your clinic next week. These are my disclosures. By way of introduction, let's talk about the three conditions I mentioned. So they all belong to autoimmune liver disease spectrum. The reason that we group them into autoimmune liver disease spectrum is they all have some specific autoantibody that can be linked to the disease presentation and diagnosis. And on histologies, they all have distinct histologic features that suggest a link to an autoimmune process, both in the etiology of the disease as well as the progression of the disease. However, those three conditions have very distinct presentation, and the treatment is also very different. Starting with PBC, we all know that it can respond to ursol treatment, but not all patients respond, hence second-line agent. PSC, up to date, there's no specific medical treatment that's effective or approved. With AIH, there are immunosuppression therapies, but not everyone responds to it either. Now, starting with PBC, this is an update on the epidemiology of PBC. And I want to highlight, this is probably one of the largest global PBC epidemiology study. Over 381 million participants, 129,000 PBC patients. And they basically group 59 population-based studies together over the past 50 years, from 1976 to 2024. The finding is, number one, the prevalence of the disease is about 18.1 per 100,000 people, which translates into the incidence rate of 1.8 per 100,000 person years. The greatest increase in PBC prevalence over the past 50 years is actually in the Western Pacific region. If you look at the graph here on the left, the green line that's going down is European countries. So the prevalence of PBC is going down in Europe. But if you look at the bottom line here, that's blue line on the right, that's the Western Pacific region, specifically Japan, Korea, Taiwan. So they account for many of the increased prevalence in PBC. The yellow line would be of interest to us. That's America. So America is also on the rise in terms of PBC prevalence, but we don't have the more recent data in the past 5 years. Among those people who have PBC, what are they? Who are they? Predominantly, it's still a female predominant disease. We see it in a location that has greater human developmental index. In other words, urban areas or developed countries tend to be in higher latitude in American region as well, it's on the rise. So that's an update on the global epidemiology of the disease. Now let's zoom into America. That's where we are right now. So this is a presentation of the PBC prevalence, the most up-to-date data that we have from 2021. The prevalence, as you can see, is higher than the global prevalence. So currently it's 40.9 per 100,000 in the United States with primary biliary cholangitis. What's interesting is if you look at this graph of the hot zones of PBC prevalence, it is slightly different than what we see in a global epidemic. In a global epidemic, we're seeing increase in high development area. But if you look at a picture here, the darker area are the higher prevalence. We see it in mostly rural America, not concentrated in urban centers or centers that have tertiary referral hepatologists. So that's an interesting observation, and we don't yet know why it is increasing in those areas. That will be hopefully a call to action for more studies in this condition. Another interesting finding is what are those patients who have AMA positive, that's supposedly a specific antibody to PBC, but have no evidence of clinical, biochemical, or histological evidence of PBC. This is a study coming out of Israel, the largest AMA positive but no evidence of PBC population reported today. They follow those patients over time, 6.3 years. And what they found is a small percentage of them actually would develop PBC, not a high amount, 7.5% would develop PBC if you follow them up. But what's more interesting is in those patients, also you will find up to around 3% of them will develop cirrhosis. So AMA positive, but no PBC may not be as benign as we think it used to be. Furthermore, if you look at a different titer of AMA antibody, those who have higher titers, that's the line here on the bottom, they have AMA higher than 320 titer, they have worse outcome. So not only those AMA antibody may predict future occurrence of PBC, as well as potentially cirrhosis, the higher the titer, the worse is the outcome. Next, we look at PBC prognosis. For patients that we diagnose with PBC in our clinic, what are the likelihood are they to suffer from PBC? Over the past 3 decades, there have been many different risk score classification, from the Mayo score to the GOLD score, to the UK PBC score. What I would propose in 2025 is to simplify them and use 2 markers for you to consider as you diagnose patients. So the study here is demonstrating the use of alkaline phosphatase as a marker. So they have a total of 6191 patients, and among them, after exclusion, they found close to 5,000 patients and followed them over time and asked the question, what are the markers that's most associated with their prognosis? And panel A is at baseline 1-year follow-up and 5-year follow-up looking at alkaline phosphatase. As you can see, as the alkaline phosphatase increase from 1-fold upper limit normal up to 5-fold, there's a linear association with their disease outcome. So alkaline phosphatase is a good marker for identifying those who may progress faster than those who would not. And if you compare to bilirubin is not as good between the 0 to 1, but after that, it has a good outcome correlation as well. The next marker for identifying those who may progress is liver stiffness. This is a study using FibroScan to identify patients with or without liver stiffness. As you can see here in the left panel, those who have higher liver stiffness, i.e. liver stiffness higher than 10 kPa, have worse outcome. And it's the most recent FibroScan data that's most relevant rather than previous FibroScan data. So this helps us understand when we see a patient in a clinic, what are the markers you can use to explain to the patient the stage of their disease as well as the rate of progression. So liver stiffness plus alkaline phosphatase. So this study demonstrated the usefulness of such approach. Basically, if you have patients who have diagnosis of PBC and you group them into liver stiffness higher than 10 kPa, which is the two lines here, and ask which one are going to progress faster. Those who have alkaline phosphatase higher than 1 times upper limit of normal will progress faster. Now that we know that how to diagnose them and offer prognosis, the next question is which one we use to treat. As we all know, last year there were 2 medications that was approved, elafibranor and seladelpar. So those are the 2 medications that we'll focus more time on this year. But just to provide some historical perspective, I will start with ursodeoxycholic acid, the first-line agent for treatment of PBC. And the reason I want to bring up this is a meta-analysis of the 3 combined randomized control trial with urso back in the 90s. And this is still the only medication that we currently have survival benefit that we know. So I want to point that out in comparison to all the other randomized control trial or meta-analysis that we're going to introduce later. And the benefit of urso can be seen in all different stages of liver disease, whether it's stage 1, 2, early disease, or stage 3 and stage 4. And the benefit can be seen as early as 6 months after treatment. Now, starting with the first approved medication, not in the US, but in Europe, that's a PPAR agonist, bezafibrate. As you can see here, we see improvement in their serum level of alkaline phosphatase. We see improvement in their serum level of ALT as well. But there's no significant difference in liver stiffness. So that's the data on bezafibrate. Unfortunately, this medication is not available in the US right now. We do have fenofibrate, that's a similar class of medication, and it's available for off-label use, but not approved for PBC. 2 of the new medications that we would talk about today. One is elafibranor. This is the PPAR alpha delta agonist. As you can see in this graph here, if you use it in people who have partial or non-response or intolerance to first-line ursodeoxycholic acid, you will see improved biochemical response to elafibranor in this 52-week study. What's most interesting is the rate of complete biochemical remission or normalization of alkaline phosphatase. Up to 15% of patients will accomplish normalization of alkaline phosphatase at 52 weeks. If you compare that to seladelpar, that's the second PPAR medication, it is a more specific PPAR delta agonist. You see a 25% normalization of alkaline phosphatase in 1 year as well. So similar biochemical response rate. This medication in the trial, we can also see improvement in pruritus, which was not significant in the elafibranor study, but in the seladelpar study, you see a significant improvement in pruritus based on patient-reported outcome. In AASLD this year, obviously there are several studies that look at meta-analysis or nested meta-analysis of the randomized clinical trials and try to distinguish which one may be slightly better. And here I will just use this poster to summarize. Basically, the first one is bezafibrate, second one is elafibranor, third one is seladelpar, and placebo is basically a patient that's on ursodiol, so only on one first-line agent with placebo as a second line. From this study, you can conclude all 3 PPAR agonists have been able to accomplish biochemical improvement in patients who are already on first-line urso. even though there may be a ranking order in effectiveness of this, but there's no statistical significance. And the take-away message is all three different PPAR agonists will be effective. That's number one. If you look at secondary endpoint, that's alkaline phosphatase normalization on the bottom graph here, it's also very similar in their effectiveness. So among the three PPAR agonists, again, only two available here in the US, the Prevalence and Delpar, they seem to be very similar in its biochemical remission rate. How about pruritus? As I mentioned earlier, the only one that has significant improvement in pruritus score is Delpar compared to elafibranor. But again, it is not a head-to-head study, and we're talking about two different study populations. But if you group all the different PPAR agonists together and look at their combined effectiveness in reducing pruritus, they seem to be effective with data from the earlier fibrate study. Bezafibrate seems to be the most effective and can accomplish pruritus improvement at a 3 to 6 month time mark. Well, so Delpar, you will start to see its effectiveness 6 months to 1 year. If elafibranor in this study did not show significant difference. How about osteoporosis? So the study here that I'm reporting are actually data collected and analyzed in our own group here at Cleveland Clinic. As all of you know, osteoporosis is one of the very common extrahepatic manifestation of PBC, and we've been struggling with how to treat those patients in terms of their metabolic bone disease. So the first graph on the left upper, we're trying to determine the risk of osteoporosis in this population compared to age-matched control by age group. What's interesting is on the left panel is patient younger than 65 years old. If you compare to post-menopausal women, they have a similar or slightly higher risk of osteoporosis. After they turn over age 65, the risk increases and becomes even higher. Further, if we look at how are we doing in terms of screening them for osteoporosis, we're not actually doing a very good job. So in terms of the screening rate for osteoporosis in PBC population, in Cleveland Clinic, our data show that we are doing it about 40 to 50% of the time, complying with guideline recommendation. And that's just one-time screening for those who are diagnosed with PBC. Do they have a DEXA scan? So 40 to 50% of the time. If we ask the question, how good are we at follow-up? So if you had the first DEXA, how good are you at following up? It's even worse. It's about 20% of the time there's a proper follow-up DEXA scan. So we're not doing a very good job at identifying those patients who may need treatment or surveillance. Even after we diagnose them with osteoporosis and start to treat them, the most common intervention will be vitamin D or bisphosphonate. And if we look at patients who are on vitamin D with PBC osteoporosis compared to age-matched control osteoporosis, but without PBC, there seems to be a decreased effect or therapeutic benefit from vitamin D supplementation. So the graph here shows reduction in their osteoporosis progression. So the control has more reduction, meaning that they are getting the benefit from vitamin D supplement. But the PBC population is less affected by the vitamin D supplementation. The panel on the left look at the bisphosphonates effect. Similarly, you don't see much benefit from bisphosphonate treatment in PBC population. So not only are we not identifying them, not following up on them, we're not treating them properly anyway. So again, this is a topic of further study and investigation to help us know how better to identify them and how better to treat them. To summarize the PBC data, I would say Good enough is no longer enough in terms of alkaline phosphatase treatment response. In the old days, we used to think 1.5 upper limit normal or 1.67 may be good enough, but the newer data demonstrate that normal alkaline phosphatase is probably the better target. It would improve outcome in that it is achievable. Moving beyond PBC, I want to talk about the genetic panel that's available now for us to diagnose patients with cholestasis. So this is from Precision Diagnostics with 77 gene panel that initially was composed of PFIC as well as cystic fibrosis, alpha-1 antitrypsin. That's now clinically available for us to use. This study looked at 856 patients who are diagnosed with unexplained cholestasis or chronic liver disease, and they tested with this 77 gene panel. What's interesting is on the left here, so out of those 856 patients, 4% of them you can identify a definitive genetic diagnosis, and another 3.5 you can have a potential diagnosis. In other words, up to 7.5% of patients in this population, again, unexplained cholestasis or chronic liver disease, that you don't have a confirmed diagnosis. Through this new genetic testing panel, you can confirm a diagnosis or have a probable diagnosis, and that can further lead to treatment. Moving on to PSC, as I mentioned earlier, we don't have a good medical treatment that's effective for those patients. So what do we do with this patient population? The first thing that I think we all know and we all do is to screen them for cholangial cancer and follow up with MRCP per guideline. However, if you look at this study, so this is done through the support of PSC partners, send out questionnaires and phone interviews with patients and ask them a simple question. Does your doctor talk to you about cholangial cancer screening? Okay, very simple question. 34% say no. My doctor did not tell me about cholangial cancer screening. Okay, so I think that's something that obviously we should do better. And if we compare different practice type, we do slightly better than our European colleagues, okay, but not much better. And hepatologists do slightly better than gastroenterologists, but again, not much better. On average, hepatologists talk to their patients with PSC about cholangial cancer screening 56% of the time, which again is surprisingly low. It also begs the question, is patient listening to what we're saying? Okay, sometimes we feel we have talked to them about cholangial cancer screening, but the patient may not perceive or realize that information. So I think there are ways for us to think about how do we improve that. So that's number one, cholangial cancer screening and education. Second question is, when we talk to those patients, a lot of times they talk about pain, this right upper quadrant pain that's persistent, dull, achy, constant. And when you look at their imaging, when you look at their biochemistry test, maybe there's no difference at all or nothing for you to intervene on. So this study asked basically a cohort of PSC patients and interview them and try to summarize and categorize what's typical of PSC pain. And 10 out of 17 patients in this very small focus group interview reported pain. So higher than 50% of the time, they have pain. And it is achy, dull, and just constant. And it may not relate directly to the biochemistry or imaging findings. This again is not an uncommon presentation in our clinic, and I think traditionally we have had a hard time sometimes convincing ourselves this may be related to PSC. And it requires us to have a better way of identifying those patients and think about how we can approach it in a different way. How can we approach it in a different way? As I mentioned, there's no effective treatment that we know of. So this study is an interesting study that looked at patients with PSC and IBD as you know, sometimes we can use oral vancomycin to achieve remission in IBD. So they look at those patients. It's a very small study, single center study of 24 patients, and follow them up to 2 years for those who underwent vancomycin therapy for their IBD, and ask the question if their PSC biochemistry gets better. So interestingly, their alkaline phosphatase and GGT all improve. So that tells us maybe there's a potential benefit in oral vancomycin, at least from this very small study. Last thing I want to talk about is this AIH-PBC variant syndrome. As you know, it can be difficult to treat, and there's still controversy on whether this condition exists or not. So this study looked at basically patients who have AIH-PBC based on the Paris or Zhang criteria, and compared to patients with AIH only, PBC only, and a subgroup of PBC patients who happen to have elevation in IgG and elevation in immunotransferase higher than 2.5 upper limit normal. The only thing that I want to highlight here is the bottom line here. So this is the disease outcome up to 10 years. And the group that did the worst is those who had PBC as well as elevation in IgG and aminotransferase higher than 2.5 upper limit normal. So this tells us that we are currently not treating this population very well, and there may be consideration for adding immunosuppression to treat those populations. So key takeaway, PBC, there are second-line agent that's available now. Who needs a second-line agent? URSO intolerance or URSO non-responder, partial responder. I would propose that we should treat everyone so that we can normalize the alkaline phosphatase. But if you have to prioritize, I would prioritize those who have high alkaline phosphatase higher than 200 regardless of kPa, or those who have kPa higher than 10 with alkaline phosphatase higher than upper limit normal. The extrahepatic manifestation of PBC are again difficult to treat, and there's a lot needs to be done. On the PSC front, we need to communicate better with our patient, listen and talk to them probably in a different, more effective way to enhance education surveillance for cholangiocarcinoma cancer. On the AIH-PBC variant syndrome part, there is a new subgroup of patients who may not fit the Paris criteria, but they have PBC with elevation in IgG aminotransferase higher than 2.5 upper limit normal that may benefit from URSO and immunosuppression therapy. So last, I just want to acknowledge some of the people who helped me with the study that I presented, especially Leandro, who's here, that helped us with the osteoporosis project. Thank you all.